let's get started. Running a few minutes behind, but we'll be able to catch up. This session will be an interactive session, so we will be asking for audience participation later on, and you'll see why.
All right, I'm going to start off by introducing myself. I'm Terry Larson. I am a proud alum of New York State College, Utica College, of Syracuse University, and I found myself in Connecticut shortly after graduation, working at a daycare center, so not even within therapeutic recreation, but I knew exactly what population I wanted to work with. I didn't know what I wanted to do when I grow up. I don't now. But I knew I wanted to work with peds. So I worked in a daycare center while I transitioned to living in Connecticut. I knew I wanted to work in a hospital setting. I knew I wanted to work with kids, and that's how I found myself at Hospital for Special Care 32 years ago. So that is Terry Larson.
I'm Jana Connolly, and just like Terry, I am a proud SUNY Portland alum, both undergrad and grad. Still love it to this day. Turnout, again, I think that, and this is an awesome show of support from both NYSTRA and all of the collegiate systems within New York State. So kudos out to every student, every faculty, every university rep, NCTRC, that NYSTRA would not be what it was, the colorful mix of members and attendees, without all representation. So appreciate everybody's participation. I ended up in Connecticut because of my internships, because I had the privilege to go out of state, and I'm from outside of Buffalo. And I thought, I'm never gonna see anything outside of other than Buffalo. So do it while you're in college. Well, you can do it and it's paid for. I subsequently was hired by both internship sites over the course of my career, and accomplished everything I wanted to, or so I thought. Again, trying to figure out, well, what do you want to do next? Where's this path taking you? And have had many opportunities over time, and they continue to open doors. So one of the things that I want to plant the seed for, and it's not related to our topic, but it's related to continued growth as a professional. Don't ever just shut the door and say, I'm where I'm at, it's where I'm going to be forever, because you never know when opportunity is going to knock. And there, if nothing else, what you will hear is what has happened because of COVID as far as opportunities that were shut down, opportunities that came up bubbling up. So with that being said, let's jump right into the how and why of where we got here. Okay, in advance, there we go. So again, we want to set the stage for you, because we don't want there to be, yes, we all have our own definitions of what are boundaries, and they vary based on cultural backgrounds, based on your personal experiences, etc. So the first and foremost, we're going to clarify the definitions that we want to be using, or that we adopted for today's presentation, to lay the groundwork. And we'll be covering definitions on ethics, the variety types of boundaries that we're going to go into, conflicts of interest.
We're going to identify the challenges secondary to COVID that have impacted service delivery in RT.
Warning signs of boundary crossings. So the warning signs are really key, very important.
Examples of those boundary crossings and strategies on how to handle them.
Examples of boundary violations.
And strategies for handling boundary issues in general.
All right, moving along.
So what's important before we kind of jump into that is a little bit of a background related to Hospital for Special Care, where Janet and I both work. This Hospital for Special Care, I like to describe it as a melting pot of a variety of populations. It's a 228 bed facility. We serve pediatrics all the way up to older adults, and we serve all of those capacities with a variety of diagnoses: so pulmonary care, brain injury, medically complex patients, neuromuscular disorders, spinal cord, heart failure, children on the spectrum, and also brain injury patients that have been discharged out into the community after an acute injury and rehab, who need a more structured, formal program so that they can be independent and successful in the community, and that's more of a community reintegration program. So there are about 11 different areas of service within the one hospital of for special care, with the biggest population being adults with a ventilator, with a respiratory component to their diagnosis, and most of them requiring 24-hour, 7 days a week ventilator support. So just some important things to know. So
in addition to that, the hospital has a community side, and that's where I spend at least 50% of my time. I am the manager for the adaptive sports and community inclusion recreation programs. And that includes training and competition for junior athletes as young as 6, 7, all the way up through adult athletes. We have individual and team sports. We follow Paralympic sport models. So, and actually we're in competition season right now for just ramping up for swimming, track and field. Just got back, my kiddos just got back from a meet in Baltimore and already qualified for nationals. Yay, kiddos. Our junior wheelchair basketball team will be heading to nationals just next weekend. So that's the good thing of coming out of COVID. We're starting to resume some normalcy, but that's a whole other side of the hospital. And again, I serve there. I am a proud CTRS, and that could be a whole other session of why is the CTRS the best provider to lead and be the administrator of an adaptive sports program. So maybe someday we'll come and talk about that. But I want to toss that out there because I also am a proud CTRS to be working inpatient on medical rehab. And again, the nice transition therein is it not great that you can get someone coming through the whole chronic continuum of care and refer them to then the community where we hope that our patients, many of them, will return. So just wanted to stick that in there before you got into some of the COVID related.
So what Janet said, part of what's important about that is maintaining your marketability. So Janet focuses on adaptive sports, but she also is a CTRS and works within the medical model on the rehab unit. So during COVID, that transition into the inpatient side of things, continue to have Janet have that opportunity to work within her field. Yes, there were many changes related to what our duties were and the different things that we did. And that's what kind of brought us to this whole topic. So we chose this because there were so many observations made during the pandemic. We kind of asked ourselves a question: what changed? I don't know about you guys, but the question I asked is what didn't change, and where did it not put us? But one of the biggest areas that we found had changed and was causing the biggest challenges for our population was social isolation, and it really hit more than just our patients or our clients. If you read the keynote, we kind of talked about that a little bit, and the fact that isolation not only affected our patients and our clients, but it affected all of us: family, staff, volunteers. It affected the outpatient side of things. Our aquatic center, our fitness center, our main solutions programs, the vendors that came in, all of our contracted services, including tutors, other support staff that comes in on a daily basis to support some of our behaviorally challenging patients. So it was all of our customers and all of us. So that's why I felt that we needed to kind of talk about social isolation and what the definition is. It's not here because we didn't really figure that out until last night when we were looking at everything. But social isolation by Wikipedia is a state of complete or near complete lack of contact between an individual and society. All types of social isolation can include staying home for a lengthy period of time, having no communication with family, acquaintances, friends, and were willfully avoiding contact with social opportunities when they arise. That's important too, because the fear and anxiety related to the pandemic also caused people to willfully choose to isolate themselves. So with this, there came this really significant issue. Patient contact and touch. There was a lack of in-person presence, but there also was a lack of touch. And that direct loss was really significant for our patient populations, and probably for a lot of us as well. So I kind of dove a little deeper in that, and I think it's a really important takeaway of today's session. Lack of touch is actually identified as touch starvation, and it's a consequence of this COVID-19 pandemic with physical distancing. You think about it, positive human touch is an integral part of human interaction. We've had it since birth. Positive human touch, warm embrace, the word reassuring touch on the shoulder, linking arms as you're walking down the hallway or the walkway. Physical contact is a large part of how we show concern, establish camaraderie, support friends and loved ones. I read an article by Shanley Pierce that talked about this a little bit, and in that, Asim Shah, MD and professor at Baylor, talked about the fact that humans are wired to touch and be touched. As I said, a newborn baby bonds with a mother through touch. When physical contact becomes limited, touch starvation occurs. He kind of compared this to food starvation because touch starvation is very similar. He described it as someone wanting to eat but they can't eat. Their psyche and body want to touch someone, but they cannot do it because of the fear associated with the pandemic. Touch starvation increases stress, depression, anxiety, and triggers a cascade of all kinds of negative physiological effects. Even for extended periods, if you have no touch, it can cause PTSD. So I just thought that it was really important to talk a little bit about touch and how important touch is within our society and our service delivery.
I work at a psychiatric hospital, so touch is like not allowed.
Yep. There are several different areas within our hospital where touch is not allowed as well.
Okay.
But I was going more on the touch of your loved one, your visitor, your caregivers that are actually able to touch, and how the pandemic kind of affected all of us in our maintain your 6 feet of distance, and the fact that those loved ones were not able to come in, and how that affected all of our patients. But when we looked further into the article, what was stated is virtual alternatives help alleviate the effects of touch starvation. And it was noted that video chatting is 80% effective, because you actually can lay eyes on your loved one and interact with your loved one. So,
Do you want to comment, Terry, on the, like how quickly the department TR staff had to pivot to that?
yeah, we actually were very fortunate in the respect that we got awarded a grant right away within this whole pandemic, and we were able to have 30 iPads donated to our facility. 228 bed facility with 95 of those patients being within our long-term care live in the hospital population, we really had to shift, pivot, and set up those virtual visitations. So instead of sitting back and waiting to see where administration was gonna put TR, kind of stepped into the middle of the circle and said, okay, these are ways that we can provide support in providing delivery of TR service as relates to the psychosocial and emotional needs of our patient population. So we will provide virtual visitation to our patient population. We kind of went by the guidelines, set up our own guidelines, but we set up visits with our population twice a week for 15 to 30 minutes. And we were able to kind of shift, pivot, and teach people how to use technology. Some of our staff was very and nervous about being able to use the technology. One of the things we had to say was, ask for forgiveness. So you're gonna hop on with a family and things aren't going right. They never go right. Especially with those challenging families that we all have that are just like, chomping at the bit. You were 30 seconds late to our visit. You're gonna have issues with that one. You just gotta remain calm, try to do the best you can, and if you can't, you reach out for some support. So we actually were able to shift our manpower, shift to room visits, no groups. We were all very lucky. At Hospital for Special Care, therapeutic recreation wasn't going anywhere. If anything, we got support from other areas. So aquatics shut down. The community piece of aquatics was not running. Their lifeguards all came to TR and were trained on in-room visits, social virtual visitation, laminating supplies, because we had to do the cleaning piece of things, supporting equipment management, bringing things back and forth between the different areas where we were providing our groups, supporting our on-unit activities, because within our hospital, they felt it was very important that our patients who lived there were actually able to come out to their common areas. So they kind of identified a certain number of patients that could be in a living area. So I felt very fortunate that we were identified as very active people at the table, figuring out staffing, looking at who belonged where, providing the training needed, and getting right in there and providing those services to our patients.
I want to comment on that, because how unique was it that TR was asked to consider taking on PT, OT, speech therapy staff because outpatient was closed. They were either given the choice of being furloughed, or if you still want to work, are you willing to be retrained? Yep, to laminate, to go interact with patients that were out of your wheelhouse. Because as Terry said, we have some significantly complex patients. So think about it. You're a PT with neuromuscular background, but you've also never dealt with the folks that are end stage Parkinson's, end stage ALS, things that are on ventilators 24/7. Some of those people were not comfortable coming under TR to get instruction, because I'm a doctorate in physical therapist and wouldn't make that transition. But those who did, boy, did they ever see the value.
It was very eye-opening. We had a couple of people who actually worked within our neuromuscular clinic who came to us, and one of the members of that team would say, wow, I don't think I realized everything that you guys do. And I really love this work with the patients. And so I run into her in the hallway now, I knew her before, But it's like, oh God, I miss you guys. How are things upstairs? How is Mrs. So-and-so? What's going on with this? Hey, the other day, I really actually thought about some of the things I did with Mrs. So-and-so and the fact that I could talk about that to my community patient, related to some different resources that were actually available. I really miss you guys. So we felt very, very supported.
Before we move on, one thing that I want to toss out there right now, as it relates to the last line here, talking about power imbalance. So boundary crossings occur when that balance between caregiver and patient need kind of gets a little wonky. But you got to realize that as the provider, it starts from day one, because as the provider of service, you have access to patient personal information before ever meeting the patient. So depending on your organization, we get really detailed age history and physical, your guidelines. So I know diagnoses, I know the age, I know is my patient married, do they have children, what was their occupation, what is their leisure interest? Isn't that great that the people are asking that now? And it's in the chart. So you're going in there knowing how much information. I know if they have a pet, I know where they live. Already there's an imbalance. And I feel strongly, and as an educator, this is something I teach administration of TR. This is something I teach my students, is that part of your introduction is to self-disclose. Self-disclose that information that you are aware that, Ms. Larson, I'm meeting you for the first time, a member of your treatment team, introduce yourself. How would you prefer to be addressed? Be respectful that you're treating a nun. You might be the only one who asked the question. How would you like to be addressed? But does it not set the stage for a respectful dialogue? And Ms. Larson, I want to just confirm, I reviewed your chart today, and I want to review some of the information that I gleaned. So it'll get us set on the, from ground one. And please let me know if any of the information is not accurate. Does it not take away some of that imbalance then? And letting the patient know what you know from the get-go. So then when you do ask some of the additional follow-up questions, it becomes that give and take. So you're on that path in a more, again, you're on the path together, not me making the decision for you, which is not our job, right? So that's an important part that I wanted to just put out there to have that understanding from the get-go that you already are stepping into the relationship and there's an imbalance and you got to correct it before you get even further in. Okay. All right. Sure.
So, and not as a rec therapist, but my husband, who happens to be a substance abuse counselor and works with, mentally ill, chemically dependent clients. And for him, when he reads their backgrounds, he reads as minimal information as possible, so it doesn't cloud his judgment to the individuals that he's serving, because he works with individuals that are sexual, assaulters, molesters, rapers, people that have murdered, and he doesn't want that information because then it's going to cloud how he treats his patients. So he just does the minimal and just goes with that. So he has a more, neutral training for counseling his patients.
Yeah, no, thank you, because it does certainly depend on the setting you're in. But the importance is to understand that relationship. Okay.
And that is a good strategy, because you kind of need to glean and know what you need to know in order for that first meeting to take place. But then you can always go back for more detail.
Right.
And you're right, it doesn't kind of set you up with already a preconceived notion of how this person is going to behave. And to kind of go off on a tangent a little bit, you're interviewing, and some of you guys were in this session the other day, and you kind of look at the person you're interviewing and already think you know who they are. Then you ask them what they watched last on Netflix, and you may be surprised by what the response is. So you kind of always have to
right, we're gonna move into definitions, and again, this is to lay a groundwork more than anything. And I like this one. This is a definition of ethics from the University of San Francisco. I don't know if that's really clear or not, but it is up there. That ethics are moral principles that govern a person's behavior or the conducting of an activity. Very simple, short, to the point, but I think that again, boom, it's there. Then we're talking about boundaries. An accepted social, physical, or psychological space between people. In healthcare, boundaries create an appropriate therapeutic distance between healthcare workers and patients and help establish goals, expectations. They're meant to provide protection. Again, doesn't NCTR that? Protection to both the healthcare professional as well as anyone that they're caring for in a clinical setting. Okay, so think about that as we're moving forward. Boundary crossings, again, I think that what's important here is with a boundary crossing, it's a decision. A decision to deviate from an established boundary that was established for a therapeutic purpose. Although many times when boundaries are crossed, it might be helpful for the patient or the client served. Okay, and often minor boundary crossings are generally acceptable, and we're going to get into examples of this later on, and they're often provided for a patient's overall well-being. So we'll get into dealing with that.
But they also are provided in an area of behavior that doesn't show favoritism, which is really important.
Boundary violations, a deliberate behavior that is recognizably inappropriate in violation of the nature of the therapeutic relationship. They often occur when the professional violates or exploits the patient-provider relationship in some way. They vary in severity, are often characterized by role reversal, secrecy, or caregivers' needs being met rather than the patient. That one I think is really important. Okay, when you turn that corner and the focus is no longer on doing the best for your patient, but making sure your personal needs are being met first and foremost. They're often, again, when we get to those, they're the ones that are the like no-brainers to figure out. They're considered serious and often a criminal act.
So we thought that conflict of interest was something really important to define as well. So conflict of interest is a situation in which the concerns or aims of two different parties are incompatible. A conflict of interest occurs when an individual's personal interests, family, friendship, financial, or social factors could compromise his or her judgment, decisions, or actions in the workplace.
Now, for warning signs of boundary crossing, there are many. And some of these I want you to be thinking about, like, okay, has this ever happened to you? Or have you, whether it was happening to you or did you ever see it? And for some of you, you may have never yet experienced boundary crossing, but that's also, isn't that why you're here today?
So just to kind of interject here for a minute, we kind of are talking about these, and these have been identified because there were a couple of stopgap moments and personal experiences that kind of were like, may I have crossed a boundary just now? So we thought it was really important to open the conversation and talk about those things and talk about ways that you can identify strategies to kind of turn back to the other corner of where you're providing service.
And just to put out there, this is not just, oh, Terry and Janet came up with all of these ideas. You'll see at the end, we do have a whole two or three slides of references. And so if this is a topic of interest for you and want a copy of our PowerPoint, one, it's going to be posted. So you know, but I don't know how much of that fine print you get. Our contact information will be there. We'd be happy to share with you. And some of these areas of boundary crossings, we kept coming across time and again. And I think that too, when we open up for some discussion, there will be some of these themes that are much more common than others. So even to the extent that, and again, many of us have done this, that spending time with a patient beyond what is time you typically would. You'd put in your time docs for your flow sheets that spent 30 minutes, but then you went back later in the day because you knew they were having a rough time. And you already took care of seeing everybody else on your caseload, and you're like, oh, I have a little free time, what can I do with it? Yes, and again, that's where when we talk about the boundary crossing, is it well-intentioned, but did I show favoritism by doing that? But was it beneficial for the patient? And that's where when we have discussion later, I think that's when it's like, oh, let's get into it, because that's something where the key down the road is going to be okay, when does that slippery slope go?
Very
So,
balanced.
yeah. I've never seen this one, Terry. The choosing patients based on factors of looks, age, or social standing. I don't know, but
Might be more like choosing favoritism, like you were saying, like, because the little kid is super cute.
yeah, right, sure.
Well, or Senator so-and-so is on the board, or, this basketball player, oh,
Terry, can I have that as can you assign me to their, it's like, that wouldn't be with me. I'm certainly not a New England Patriot, please. I'm a Buffalo Bills fan, so I'll through. I may live in New England, but I will always be Buffalo Bills fan. So, yeah, I have seen this one. Responding to personal overtures by a patient. Sharing personal problems with the patient. Dressing differently because of who you're going to see today for your patients. I've seen that one. Frequently thinking about a patient outside of the context of a therapeutic environment.
Yeah.
Being defensive or making excuses when someone might comment or question your interactions with the patient. Okay, that should be right there, right? Being hesitant except for reasons of confidentiality, or being embarrassed to discuss the relationship between you and your patient. And the ones that were focused on some of the articles were in when you're having to communicate in team meetings. And people are asking, well, tell me a little bit more. Well, we could get into it at another time. Making excuses for not wanting to self-disclose. Well, what do you know?
providing the patient with a home or cell number or email address, or your Facebook friends, unless it is required in context of the therapeutic relationship. And maintaining a patient on treatment plan longer than is required.
Because they're your favorite. So boundary crossings, let's get into this a little bit. Again, they can be very simple. And again, depending on where you work, cultural norms come into play. They do certainly where we are. New Britain, Connecticut is a very high Polish community. Some good things with that is traditionally Polish community are stellar caregivers. They look at their family. So in this case, their patients are part of their family. So inherently, there's already that imbalance. But they take pride in super high service delivery and how they prefer to address their patients. And it might be even in Polish if it's Polish patient. I don't know what they're saying. I don't ask. But it is using nicknames. How you doing today, dear? Honey, how's it going?
We also have a high Hispanic population.
Not quite as high as Polish, trust me.
But again, it's kind of it's a different culture, and a lot of the patients are, mommy, how are you today? With a quick touch. So just another, like, it's almost, they become a part of their family, and this is my patient, my mommy, and, you know, it's meant more as a supportive, you know, interaction, but it's not necessarily an appropriate, respectful way to address your patient population.
Gifts are up there again, that one of the things that needs to be noted by gifts, again, especially for those who are in an environment where you have patients that you're working with for an extended period of time, or in our case, where some of the patients live with us for years. And so certainly, whether it's holidays or somehow the family found out it was your birthday, don't know how that happened, and it's little things. But part of what some of the articles came right out and said was there's a fine line of both interpretation and when is accepting a gift appropriate or not. Our organization has a whole policy. So do many organizations. And if you are, you know, do you know what your organization's policy is about that? Because are you violating, and what do our professional standards tell us? But also other family members. If brother of said patient came in and said, you know, I just want to really acknowledge you for, you know, all you do to go above and beyond for my brother. So I want to make sure you have this. And then the mother comes in and says, what? Sometimes that gift can be construed as, you know, way out of line by a family member. Or in some cases, it might be, we have some incredibly talented patients in the sense that we have an art group in which we have professional artists and highly talented individuals coming in to facilitate that group. And the artwork that some of our patients turn out is amazing, can be sold, but instead the patient's gonna give it to their favorite person.
And that's kind of like a
Nothing. So even things such as, yes, failing to respect patients' privacy during COVID, that was a really big one. Purchasing gifts, lending money to a patient, some of these, yep, came up again and again. Even the basics of, again, for your patients that are there with you a long time, purchasing toiletries or just day-to-day items just to make their life more comfortable and easy, and so they smell pretty.
And it doesn't necessarily need to be purchasing those items with your own money. It could be purchasing those items with their money.
And how about this one for, could it be, well, there's a big issue with the last one, not charging or documenting for services that you rendered. Oh my goodness, let's not go down there, folks. All right, let's talk about strategies then. What if you sense or you're aware you know somebody else who crossed the line? What do? First and foremost, do you know the hierarchy within your organization? So you all should know who your supervisor is, your immediate, but it may not be your supervisor. But even with that, I would say you need to go directly to whom you are comfortable with having that conversation. It has to be reported as soon as possible.
And you might want to go to step 2 first, possibly. If you observe it and it could be a boundary crossing, you might want to engage in a conversation with that peer. You know, kind of talk through it in the spirit of high reliability as a high reliability organization. Kind of, hey, I noticed that this happened. And if you're comfortable doing it, that's great. And it's, you know, kind of discussing it. That might be considered that. But maybe we need to talk about that more as a group.
Certainly, I just said earlier, do you know what your agency organization's policies are? Some organizations have a whole ethics team that, or a hotline, or, you know, a private means of dropping off a card in, what is it called in our, you know what I mean, anonymous viewpoints, that's what hotline.
Yeah.
Even that too. So if you have a team, consulting with them. If you practice on your own or an organization that doesn't have that, Do you have colleagues that you can just call and say, hey, Terry, I'm working at such and such now. Can I just run something by you? I'm not sure. Can you help me figure out, was this really a boundary crossing? Like, do I need to do anything with this information that I observed or, you know, can you help me talk through this whole scenario? And let's moving on. Personal. Okay, I think we're into the fun part now. Yeah. Actually, before, well, no, yeah, we're gonna do that. So now we're time for audience engagement. So, first off, by a show of hands, who has either experienced or witnessed either a boundary crossing or boundary violation? Just about everybody. That's okay, because we have scenarios made up for those of you who have yet experienced it. And what we'd like is for you to get in groups of 2 or 3, share your experience, and then come back and decide that if there's more than one experiences and they're all different, decide which one you're going to want to share, or if there's 2 from your group that you want to share with the audience and share what the experience was, how it was handled, if there was a, you know, again, positive or negative outcome.
Yeah, and how you feel about that, or maybe an alternative way that you may have handled that situation, because that's what we're here for, is kind of look at those, identify them, talk about them, and be able to step back into practice with a little bit different viewpoint. And
Jason, we're up at 10:30. Okay, so that even though we started a little late, we should be good. Because I do think this is a really important piece, because I'm real curious too, to see if some of the things that bubbled up in some of this lit reviews that we did are the same experiences that you all have had, right? So why don't you get in your group, and then if there's somebody in your group who needs a situation card, put your hand up, all right, and we'll come to you.
So where I work, I work
Okay, we need a card, hand up. Anybody with a card?
And nothing seems to be
Perfect. Wow.
So I've enjoyed every area. So our units are 25. Yeah. Yes, I remember, we used to get kids from
It's a little bad.
First Friday.
How many staff? Okay. Yeah. Yeah. Yeah, no,
More minutes.
children's unit for many years, and that was the case there. And now I'm on adult inpatient. The adults want that touch, they crave it, but it's like I'll do an elbow bump, I'll do a fist bump, Yeah. Yeah, I have this patient who calls me 20 and says, I love you. I'm like, no, you don't. Not appropriate, but still, that's every time I see it.
All right, if you can all just again wrap it up, and hopefully you've decided amongst your group. Certainly what do you think was the top boundary crossing you'd like to share? And if there was more than one, we'll kind of circle back around. And I'm gonna be writing down what some of them are, because we have a whole, as I said, I have a whole list and card stock going here of all sorts of boundary crossings that we have encountered. And we just want to add to that for, again, future presentations and or just, again, additional info share. Maybe we'll even put that together as a follow-up. So if anybody wanted additional information, I'm sure there's a way on your, evaluation form to put your email, your address, and Nystro will find some way to get that back to us. Okay, so is there any group that would like to lead us off?
I'll share first.
And please speak up so everybody in the back can hear you as well.
Okay, I'm Stephanie. I'm from Hutchings Psychiatric Center in Syracuse. I see a lot of boundary crossing staff to patients. One that happens a lot that I see is I do a lunch group for patients, and we used to go out, now we can't, so we just order in. And a lot of staff is like blah, 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 wants to attend, and I'll be like, well, they don't have any money in our office. I can try to contact families, some of them don't have families, so the staff volunteers to pay for them. And I tell them, no, I can't accept that, and then miraculously, the patient all of a sudden has money and is able to participate. So.
Yes, because I'm assuming in your, in the environment you work in, patients, some of the programs that you do, patients need to have the financial support in order to participate.
Exactly. And it's not like a big group where we do everybody.
Right.
It's more of a smaller group.
Great example, thank you.
I think collaboratively, we all have definitely passed boundaries where we play favorites. But I think the interesting conversation that we had, I'm sorry.
It's just Noel's tendency here.
But I think the interesting conversation that we had was, we are talking about boundaries, but when is it really the crossing? Because we are innately helpers.
Yep.
We are innately enablers.
Yep.
And we are there to create that therapeutic relationship with the individuals that we serve. So when does it ultimately become that crossing of the line? And I think we really talked a lot about that with us, because, we have favorites, and it's human nature to have that particular patient or client that reminds us of grandma or mom or dad, or the whole transference thing. So I think that was collaboratively what we had come up with that.
So did you come up with then, you didn't come up, then what do you do? Well, I think one of the answers there is, again, going back to.
We're all bad therapists.
So give us one example of that, right? Like,
Buying cigarettes for patients.
because they're your favorite.
Not because I know what they're gonna
Yeah.
act like, and they know that we are gonna give them the cigarettes. We'll purchase them for them, so they come to
Okay,
us.
so it's almost like a tool, a bribery tool. Kind of like the same thing, I hate to say it, but you have food, and your staff's gonna come to the
Yeah.
meeting.
Right, absolutely.
Feed them, they will come.
Right,
Yeah.
it's kind of that same thing, but, so let's talk about that a little bit. I mean, because that's where we are, right? Like in that safe space. So Janet, write that one down so that after everybody shares, we can kind of talk about the strategies that we would use related to that situation.
Well, and I think the short answer though is remembering that it might be a patient favorite, but in your mind's eye, you may go like, oh, of course they are. But are you going so far as to do something for just that one patient? Or would you do that same act for this patient and this patient when they came into your care, and this patient and this patient? So do we not have favorites continuously? And so I think that's something that in your wheelhouse is, by nature of who we are as a caring profession, we just care for everybody.
Right.
And then, well, I mean, we can give you some really
But
in-depth
That's a
scenarios.
good question, and that's a good question to ask yourselves as you're kind of going through this process.
I don't know if I'm jumping ahead, but isn't just the, and maybe I'm wrong, but, isn't the field of TR sometimes blurring those lines?
Yes,
I mean,
yep. And that's why
our
we're
whole
kind of talking
job
about
is-
it.
I mean,
Yeah.
we're recreation therapists, we're everybody's.
Right.
Everybody loves me, it's the best, but like, I feel like our favorites kind of pick us too, like we
Mhm.
subscribe to certain people, and I think we all have, at least three of us collectively had like an example where, you know, you just got along with that person really well, and it just, that person responded better to you, and got better care because you were there versus somebody else, so it's not.
These are all great examples because we are gonna get to that transition phase of when is it a boundary crossing to then, okay, that slope of becoming boundary violation.
Right, and finding that balance. And that's what this is all about, is finding the balance once you've kind of stepped in it a little bit.
Okay, why don't we keep going in this direction and we'll eventually work our way back up here. Next group.
So, I'm in long-term care. My assistant, the resident in long-term care, after she came in, they got talking, realized they were just late.
Oh,
So.
okay, so staff is related to patient.
This woman was, you know, her health was. She said, when I die, I want to have this painting in my room.
Oh.
So if she dies, my staff member comes into the office with that painting. I said, you can take this. She said, but she told me I could have it. I said, well, in this, you are still an employee here, you're not wrong. I said, if the family wants to come take the picture and give you that picture in your private life, that you can't physically take it from her room.
Because it be considered.
So great example, because that was something that came up, but you're perfect, that you're saying, no, it does happen.
Yeah.
So awesome, thank you for sharing. In the back there?
So this example is a boundary violation, and it would be a criminal act today at the establishment of the New York State Justice Center. This is pre-Justice Center, it's happened in 2010. So it's when I was a new professional, and the staff member was a mental health counselor who started with our agency as an intern. And at the time, we had a patient who was mandated treatment by our county drug board. And insurance laws have also changed. So he had had a very long stay. He was in inpatient STD treatment for 100 days or more. And he had started while she was an intern. She was hired out of her internship. And the clinical staff decided that she should take him on a walk outside of her day just to keep him getting fresh air, moving, being healthy, and not sitting to the same program over and over again. These were brief walks. They were not significant, like 15 minutes just to get good fresh air. And she and I were friends, and like outside of work, we would hang out sometimes for about dinner after our shift meetings. And he eventually that opened up because his mandate had to go to a very particular Pennsylvania residence, and the bed finally opened. He left treatment with us. And a couple weeks later, she and I go out to dinner, and she says to me, "Jackie, I'm so excited, I'm in love." I said, "Oh, it's so exciting! I'm so happy for you. Who is he? Like, tell me about him." And she said, "Oh, well, it's," and she said the person's name. And I just sat there for a second and said, "Do you mean your patient?" And she said, "Yes." And I said, "Do you realize you have to resign your credential and your position?" And she said, "Yes, I just put in my 2 weeks of work. And I'm leaving the field." Wow. And so she had just completed a master's degree at a private school that cost a ton of money. She was a really promising therapist. She was already being tapped for leadership, like recognized as like a rising star. And so she had to leave the field. And sadly, about a month later, he experienced a return to use and their relationship ended. So it was very interesting because there were some people who looked at this in our workplace and said, "Well, he victimized this poor young woman." And the opposite is true.
Yes.
She was in a hierarchical relationship and took advantage of him, and most likely contributed to his return to use. So it's, yeah. Wow. She, not actually, at Walmart.
So I had a similar situation. Fortunately, it wasn't with the recreation professional. But I work in a long-term site, and with the use of the iPads, I was managing the secure care unit, which is for patients who have difficulties, interacting on those units. They need more carefully. They may be violent. And so I gave the patient the iPad. Well, the rec therapist on the unit gave the patient the iPad. And somehow when we got the iPad back, we recognized that this was not an approved number that was called. And after further research, we realized that it was one of the direct care staff that he was calling. And he admitted to us that he was in a romantic relationship with her. Over investigation had to be done.
Yeah. I do want to also point out, the seat jumping, that these things are illegal in New York State now and require calls to the Justice Center for reporting. There is no possible consent between a patient and a staff person. So, I mean, these are that happen now. It's, you don't call for also.
You're making it so easy for our next slide that we're gonna just be able to go right through
That is
it.
great information. Thank you.
Where I worked, at
Yeah.
the time, like, it doesn't exist yet. But if that had existed and I had not reported it, I would also be.
Absolutely. This is all great stuff, and I'm so glad you are sharing. So, quick, Owen, back here.
Sure. I work in long-term care, and we had a resident who was 106 years old. And she was, as the state came in, and because we had a 106-year-old resident who was very alert and oriented at the time, the state was like, that's gotta be one of our interviews. And as I'm saying this, I realize that they're playing favoritism, but that's not a part of the story. So they walked out, and the nurse walked in and knocks on her door and goes, Grandma, this lady wants to speak with you, and and everything. And the state worker looked at her and goes, is she related to you? She goes, no, that's her. That's how she prefers to be called. That's what we all call her. And the state worker walked out of the room and was like, thank you very much. And they were going to tag us for a dignity issue. Very quickly, it was pointed out by the executive director very quickly that she was alert, she was oriented. It was documented that that was her preferred greeting, that was her preferred name. It was care planned in everyone's care plan not to call her grandma. And it went to the point where it was on the back of her chair. It said, hi, my name is Catherine. Please call me grandma. And, but the state they really wanted to nail us on that dignity.
Did they end up, or because you had the documentation, you guys were good?
Within 5 seconds of calling the supervisor was like, is she alert? Is she oriented? Did you document it? Did she give consent? And we were like, yep. She was like, no violation. She was like,
That's really great that you guys did that documentation.
Yeah,
That's
yeah,
impressive. That did save you.
Lets you know how important it is.
The only
No, that's
thing,
great.
Like, especially new people, or even as an intern, like, I interned at a senior community, and I don't think I realized like how much of a dignity issue that is, and people don't realize that documenting something like that would be actually beneficial for you, even though it's just some comments of the and they refer, like caffeine fever.
Wow.
Great, thank you. Next group.
Well, where I work, we have like these things called small houses, like it's like a little personal home, like we have a deer, it's a Jewish facility, so they'll call it deer, they cook, they clean and everything for the residents, they have a big long table, little like living room and stuff. And the families there, since it's like they call it the VIP because it's, small houses, like to give, something at the holidays to show their appreciation. So a lot of them want to give like, like money in cash, and I told them that we're not allowed to, according to the social worker, we're not allowed to take monetary tips, but if you would like, you can give something that we can share with everybody, like food or something that we can share with all the
Yeah.
staff members. I said we can't like take individual gifts. So.
And did that work out?
Yeah, then they gave us some people, but then other people would like give like gift cards. So I didn't wanna like offend the resident or the family member, so I would take the gift card, I would go out and buy something for the house. And say, here's a treat, like donuts or like Hershey Kisses or something like that, just buy for the house, and say, here, pick this up for everybody, give this to anybody who wants it.
Great, great.
Just to follow up on that, you obviously at CTRC, we are not a clinical setting or a TR setting, but anytime we get gift cards for presenting or any sort of gifts, we are also not allowed to take gifts. So we'll always like hand them in to our executive director, and then she'll like buy something, just so everybody understands.
Yeah,
that it's not only within,
Right.
Right.
a clinical setting that occurs, it occurs for us as well, so.
Thanks, Noel, because it can be anywhere. But it still is, know your ethical bound, your inner compass is really, really important. Jason, great,
I would just add that we're documenting that, it's really important too.
Yeah.
absolutely.
There's a paper trail that backs up, that took this gift from and shared here. Just in case anything comes up in the future.
Absolutely.
It's really important.
Absolutely. Okay, now, do we have one or two? Well, one, because you guys already went. So, yep, perfect.
So we all work in senior living as well as assisted living communities, so we had a dining room server that she actually recorded herself to say she played favorites with one of our male residents. So she recorded herself by saying, oh, another resident keeps accusing me of, loving him and going in his room and doing all kinds of crazy things. So we're like, well, now we have to investigate it, make sure nothing's happening. And then the next day was this gentleman's birthday, and she, fully decorated his whole table in the dining room, stashed on the chair, cake and everything. So she's saying that residents are accusing her of things, but then the next day, that's why you're being accused of that. So she's no longer with us, but.
And I guess the takeaway with all of this is just what you've heard, that we're in this profession because we care. We're in this profession because we have the power to do good. We're in this profession because we can do a lot. We are the creative, we are the givers, we are the problem solvers. But it can trigger into some other things.
Human health service, we're all human. So, one of the things I've learned in the last several years working where I work is, that high reliability comes up all the time, and like engaging in conversations to kind of talk about some of those missteps, walk through different strategies you can use so that you don't have a misstep or really step in it. So that we all are holding ourselves accountable for our provision of service in a very appropriate way. So let's kind of shift back to defining. Oh, okay, sorry. Yeah.
Yeah, we're gonna skip this one pretty much altogether because I think that there is a very keen understanding that a violation is a violation is a violation. It's egregious. It is often punishable by, criminal intent. You're gonna be taken up on charges. You could lose your certification forever, and more. Okay, so we're not spending a lot of time talking about boundary violations. We're spending time talking about, the strategies and tips for success when you figure stuff out, when you come across things. So go ahead, Terry, yeah.
So cigarettes, buying cigarettes for a client, patient, because then they're going to come to your session and have a positive outcome, right? Is that kind of the gist? What do you guys think?
Crossing the line.
Crossing the line?
I think.
Is that a lot of
Why? For what reason?
Because you're
Somebody said it could be coercion. Jackie?
Smoking cigarettes is illegal in most healthcare facilities or probably in your state. But it could also be illegal.
I would say it's bribery.
And that too, one of the things that Terry and I didn't talk about, but that we talked about when we were creating the presentation, and this could be a whole yet other topic, was when is something a violation of professional ethics and guidance and that moral compass, and, you know, again, so violation of professionalism versus boundary issues. So no, again, hopefully some of what today's presentation was is there's boundary crossing, boundary violations, conflicts of interest, but there's professional. You stepped over that line. And when is something a professional judgment, poor judgment call is different. Okay.
I was just gonna add, so like, the issue of bribery and reward is one of time. So if I give you something after a behavior to calm you down, I'm bribing you.
Yep.
If on the other hand, I establish before whatever happens, like, and it doesn't happen, then I'm rewarding you. So it's about how you set up. whatever
Thank
it
you.
is
Say,
you're
how
setting
is
up.
giving, I mean, like, I know it's different because there might be a legal issue, but like having donuts at a wellness meeting, you want to come unless there's donuts, is that bribery? You know, like, it's not
Right, I think
cigarettes, I
we've
know
got-
that's drastically different, but it's
Right.
similar to what you said, like, you
Yeah.
can come and get this, but it's your choice whether or not you want to come and
Yeah,
get
and
this. I'm
that's
not
a great-
saying you must do this in order to
So,
get
yeah,
that.
exactly. So that, as soon as you say you must do this to get this, then that's more of a prize, but the
Right.
idea that this is something that we do.
Offering a choice.
Right, and again, it's open to everyone and available to everyone. It's easy to say like cigarettes are bad for you, but so are donuts.
Right.
And a wellness group.
I know.
Jackie's
Jackie,
got it.
yes.
Also, like, keep in mind, if you would say it to your supervisor that you're doing it, and you would be willing to document that you're doing it,
Right,
that's a really, like, good way to look at it. Like, when I put in writing that I'm doing this behavior.
yeah, would you train somebody to do
Correct.
that?
Is this the standard that you're setting, or is it something that you're keeping secret about? And it's a question, can you justify it?
Right, right, yeah.
What is the, and are you willing to justify it?
And I do-
Critical reasoning behind it.
And I do think it depends on where you work and what setting you work in, because at one point in time, on our neurobehavioral units within the hospital, you may have gotten your cigarette break removed for some of your behavior within the program. So you know, my thing about cigarettes versus, you know, other items is the fact that we all know from a health and wellness standpoint, donuts too. But, in moderation, right? But that, you know, cigarettes are not good for your health. So, and it's something from a health and wellness standpoint that we are educating, but it really depends on your facility or your organization. So we have to keep in mind Jason's point. Anybody else want to talk about strategies related to the situation they talked about?
Or comment on one of the ones you heard that either they didn't, either you have another outcome.
Well, all of our examples, many of our examples were about like playing favorites and things, and when I worked at ARC, my office was in a day app facility, and we had a behavior specialist on site, and a lot of the rooms were either highly behavioral or had needs, and the behavior specialist would tell everybody, like, everybody has favorites, because like I said, like, we naturally gravitate towards people, or they gravitate towards you, and he would try and like let everybody know that yes, you can have a favorite, but everybody should think that they're your favorite. So if you are, like, we were saying, you know, playing favorites or doing special things, or she was talking about getting special treats for someone, but if you would do that for somebody else, just because they gravitate towards you or they ask for it, you probably would say yes to them too. It's not like you just picked that person out and said, I'm gonna be nice to you or be special to you. But he would talk about, like, you know, make sure everybody thinks that you're their favorite, but he also had a favorite too. Like the girl would walk out of the room with like having terrible behaviors, like, you know, bashing her elbows on the wall or something like that. She'd walk out and then, hi, and her mood would just flip because he'd like, make my heart smile, but he would say that to everybody. All the things that she loved about him, he was like proud of everything.
And I think that's one of the things you gotta think about here. you know, we were talking about easily gaining a report with a certain person, and that comfort. I know we have no time left, but you gotta think about, are you gonna treat everybody that same way? Just a great open conversation about thinking about your practice, the way you practice, those boundaries, and taking that into consideration in your everyday interactions with your patient population. Thanks, guys, for coming.
Thank you. The evaluation on this chair. Anyone who doesn't understand,
That's what we.
Thank you. So I found out one of my staff, so community-based, people who live home on their own, he was getting divorced and he was like,
I'm actually friends with them.
So I don't know what the. Is there a Jennifer in here? No? What? Jennifer?
And you, maybe it's just like, it's nice to see people. So, yeah, such a discussion, what do you
They
think?
definitely don't have.
We're like, okay, well, let's just, that's how we met.
Yeah.
I wanted to see that.
Where should I find?
Just to put into effect that, you know, NCTRC does have a protocol.
Yeah.
If that ends up happening, we did actually have a situation where NCTRS had a relationship. So it does happen.